So may I encourage all eye surgeons who are watching this seminar to go a little higher in your strike. Surgery is great, but it doesn't correlate with vision. You must aim for vision. Surgery becomes secondary, like driving or cooking. It just happens. And your focus on vision will change your life and those of your patients. So unleash vision. I want you to focus on this particular slide. These are everyday patients at my institute done by brilliant surgeons all over the world. Surgeons' notes explain a well-centered lens or a great-looking transplant or smooth topography. Patients are seething with anger because they are not seeing 20/20. Again, excellent surgery, the direction is vision. All of these patients can be corrected very easily. That's what I'm going to share with you. But I really want to share today is let's talk beyond surgery all the time. So the target is vision. It's not surgery. Surgery, what I tell patients, is my excuse to get there. I have to drive the car over the hill, but my destination is what's my focus. Surgical acrobatics doesn't equal to vision patient satisfaction. Vision is what our focus has to be, and then walk backwards to surgery, work further backwards to technology. Look at all these patients, and these are the slides. These are patients from 9 countries, 11 states in one day. All of these patients are seeing 20/20. So please look at the slide pictures up there. All of these patients referred for transplants and other major surgeries to be done. 4 minutes, please. Let's keep going through this. I call this stop the train wreck. It's all about attitude. All about attitude. Do not get so consumed with the posterior subcapsular cataract that you forget keeping the chamber height low, keeping the iris of the capsule to prevent posterior block, because most of these patients have myopia, and taking them with the plowing technique to excellent vision is the endpoint. Taking patients like these who come in, one-eyed patient, anterior posterior capsule completely adhered, partially absorbed, traumatic cataract with VR surgery. To me, what is important is not the surgery of anterior excess, posterior excess, or putting the lens in, which I did. It's the next day when this guy dresses up like this and is seeing 20/20. That's what I want every eye surgeon to be addicted with. There is no need to see this eye next day because you see the way he's dressed, and he wanted this picture to put on his Facebook. Now, I want to share with you, patients do not come to you for surgery. Let's get this repeated. Again, all of you amazing surgeons here, some of my very dear friends. Patients do not come to you for surgery, they come for vision. And if they've had a bad outcome, they're really not looking for surgery. They wish there was a pill they could take. So what you have to deliver is vision and the experience. They're going through post-surgical stress syndrome. They don't trust anybody. And when they're flying to me at this point, they've been through some marvelous surgeons, but they all miss the point. I want you to see this because in every surgery, in every presentation of mine, I show you patients. I believe that is the highest accountability, not a white paper. A real fully paid patient who wants to go and explain their life to the whole world, that is true outcomes. Why is this patient right in surgery, who's had 10 previous surgeries in Abu Dhabi, why is he saying he's happy?
Fantastic.
Hear him, please. He's in surgery.
Super.
I'm enjoying your light show.
That's what you want, the patient experience. This is the 11th surgery. Every patient of mine is topical, no drugs, no IV sedations, no IV prick at all. The night of surgery comes, he rents this bike, wants me to sit on his bike. That's my confidence that I can sit there. This is his 11th surgery and he's flying to Abu Dhabi next day. Why is this attorney and Coast Guard officer doing this? These are very serious people who came in very angry. Why are they doing this? I want you to please look at this and remember, it's their experience. Why is this patient on multiple surgeries from Arizona doing this?
Hi. How you feeling?
Oh my gosh, I feel remarkable.
All right, I just want you to remember this, please. Patients come for vision and experience. Now, I recently gave an interview in OT, Ophthalmology Times, where I said, show me the patients. Actually, I was before Jerry Maguire when he said, show me the money. So 3 decades ago, I would say this to my colleagues out of jest and fun and to encourage them. I don't want to see your surgery video if you cannot show me your surgery during surgery, smiling, immediately post-op hugging you, and next day dressed to kill, trying to fly out. That to me is success. So show me the patients. These are again patients of day one, all came in with bad outcomes, all leaving with an amazing outcome. So what are the principles of a surgical strike? When Dr. Rohit sent me this title, surgical strike, I like it to be refractively oriented, not topo oriented, none of that technology, refractively oriented, visually targeted. Target is vision, not surgery, and swift and minimally invasive. And your endpoint is to avoid a full-blown invasive surgery. That's a surgical strike in eye surgery. Let's get that clear. It's not about going in the eye, suturing the lenses, getting the vitreous out of posterior excess. That is great. A surgical strike is artistic, minimalistic, visually oriented. In the eye world, I had written my article on GPS. It came to me known as Gulani planning system, which is you don't get into your car, start driving and see where you land. You plan your destination and take the best path and play up the music while you're getting there. So how do I approach every case, from a simple myop to the most devastating surgeries that are flown to me? I always think vision. If somebody has a dagger in their eye, I tell my fellows, I want a one-page report on why this patient will not be 20/20. It's an attitude thing. So I first think vision, I then think surgery. Second, and last, I think technology. Meaning I walk up to my kitchen to pick up my ingredients, because now I'm crystal what I want to use. I don't debate about that. Here's the patient. Let's go. I've taken 3 particular cases from my everyday cases to show you how I think. And these cases will line that out so we can talk about the higher strike. So here's a patient with 9 surgical complications, 89 microns keratometry, 23.5 astigmatism, told nothing can be done, HEX K, you'll see this. And what did we do? My concept, which I'm going to share in the next case, is I start thinking, how can I make her 20/20? And no, I will not do the transplant that she was flown to me for. I will not do anything that will take me away from 20/20 without glasses, please. We are eye surgeons. I don't like to discuss glasses contacts. Our attitude has to be perfection. So we first put in an intact. I don't care what intracorneal rings you use, but bring the cornea to what I call measurable before we enter the sacred eye. So 23.5 to 1.4. Here's a video. I'll let the volume take over. This is a 75-year-old nurse
Can you hear it, please?
referred to me following hexagonal keratotomy with corneal ectasia, vision of round fingers only, and Fuchs dystrophy, along with associated cataract and high keratometry of 88 with high irregular astigmatism of 23.5. I planned first to stabilize and make her cornea measurable in sync for future cataract surgery. Here I am using intacts, and as you can see me, I'm using her own corneal resistance to guide my intact rings in place. I'm doing this without any sharp intervention, so I don't make mistakenly any incision that can go into the hexagonal keratotomy cuts and perforate the cornea.
Manual.
Again, notice these are very determined yet very careful movements of the ring, and I'm placing them so as to embrace this central unstable island. The success of this is immediately reflected in the central light
Please notice the central
if you
reflex.
notice, which is becoming more and more circular, and I call this the titratable concept of intact surgery. Notice again, the light reflex is now a perfect circle. I'm extremely pleased to the
I
point
usually
that
do not do cross-linking at
cross-link.
the same time
This success
ever
is
because
reflected in
accuracy.
topography from 23.5 to 1.4 diopter astigmatism.
Please see the patient dressed up 60 years later.
4 months after determining
Stability
stability of this cornea,
and accuracy.
so we can determine accurate cataract surgery. We proceed here. Trypan blue for the observing surgeons. Viscoelastic exchange.
Manual.
I plan my capsular excess to be a smaller size so I can see the edges between the HEX K cuts and the intact reflections, and also to maintain a good
Remember,
lens
my mindset is I
capsular
want
diaphragm.
20/20. I can easily do a
I now
major
proceed
surgery.
with what we
Not
call
right.
phacoeplastic, which is doing cataract surgery also in determined steps. Like you see, my phaco probe is not moving. It stays in
I
one
don't
place
want a
while my
stitch.
second hand does
Cannot
most of the
tolerate a
movement
stitch.
to maintain a stable
Stigmatism.
incision. Similarly with the IA and lens insertion here. Lens is now being placed in the bag and then gently moved into its axis. Again, irrigation aspiration, well-sealed incision, further reinforced
For
with
travel.
Reassure sealant, no stitch to induce any astigmatism. So here we have taken a patient who was denied her vision for 60 years. In few minutes surgeries, 4 months apart, we have restored her vision and her confidence to give her back her life, where she's come back to nursing and helping other patients. Here she is immediately after surgery, and here is my payback, seeing them smile
Without
and
glasses.
free to lead their life and help others. Once again, thank you for your attention.
Even if you forget the whole surgery, please remember this picture of this lady. Exophthalmos, Fuchs, ectasia, HEX K, 23 diopters, everything I told you. This is the $1 billion I want everyone to be addicted to. Now, a quickly brush up on the clear system of mine, where I do not like doctors calling themselves cornea, LASIK, or cataract surgeons. We are all vision corrective surgeons. Clear means keratolenticular extended armamentarium, which is 48 techniques to make people see without glasses. Blur your boundaries. I want every patient at 20/20. You're a master chef. Stop depending on robots and technologies. Enslave them. Therefore, my title, Enslave Your Technology, Unleash Vision. You are the master chef. Take credit for it, please. So when a strike, I would also correlate this to a bowling strike, how I think with every patient in my 5S system. I like to. Now, let's go to this case, which shows you my thinking process for every patient. Here's a patient in for a lawsuit with a surgeon, keratoconus, a premium cataract surgery done, ended with hyperopia, high case, central scar, and open PC. What would you do? Patient is 2200 and miserable, and he also was a pilot. Ks are 49. Here's how I start thinking. I start putting him into my 5S system, which I've written about 3 decades ago, which is how my brain thinks. I call it the mental sorter. I refuse to think about surgery. I'm thinking, what do I need to correct? So if you see these pins I have lined up, I have pounded him a corneal scar, astigmatism, presbyopia, hyperopia, high keratometry. Can you see the pins down? Now that I've lined them up, I have made myself accountable to the patient. And now, how do I aim for a strike? Having lined them up, I want every pin down. That's your attitude. You cannot go, this is a difficult case, I'll get 2 pins. I want it all. So that's the system. Having got that, here's the patient and the system and the problem. He's hyperopic, presbyopic, astigmatism, corneal scar, high case. So with my clear system, the only one surgery, remember, I don't give patient options. You give them a plan, which is the correct one. You want myopic laser surgery as the only surgery that can get me all my 7 pins. My dilemma. How do I do myopic surgery when he's hyperopic? So if you see this patient who was seething with anger, had his attorneys with him, had 2 of his surgeons in New York on the point of lawsuit, he's sitting in my office. In 20 minutes, he becomes a puppy going, wow, doc, so your problem is very simple. How will you make me myopic? I said, that's exactly right, Jim. You got it. I have nothing else to worry about. Your surgeon's done a great job. My concern now is how do I think of making you myopic? You see how all my problems funnel down to one thing? Now, how do I make him myopic? Very simple. He's a keratoconic eye, meaning deep chamber. He's got an open capsule. Remember, I can show off my surgical skills, 4 minutes of removing the lens and putting a new lens in. Wrong. I'll be disturbing the vitreous, no 20/20 potential. So I'm going to put a piggyback lens. What I call this for this patient, I tell him, listen, here's the ticket to Paris, which you want to go to. But can we go to Iceland before that? And you have to trust me, Iceland's dark and cold. Paris is sunny and beautiful. But you got to trust me. So the patient needs to trust you, and you need to trust yourself that you can take off and land 2 times, because if I crash in Iceland, it's over. He's not going to Paris. So if you look at this concept of mine, Orlando to Paris via Iceland, you can see the ticket right up there. And what I do here is I tell him, here's where we are going, and you're confident with me, even though you're shivering in Iceland, wondering, what the hell am I doing here? I was supposed to go to Paris, which is 20/20 vision. So I first put in a piggyback lens and actually made him worse. Do you see what happened in Iceland? The vision is worse now because I made him myopic astigmatism. And then with laser, I bring him to 20/20. And the patient is smiling throughout because they have to trust you on this journey as you trust yourself. So that's a concept of how you take patients, even if you're playing racquetball or carom, how you play and you bring them to 20/20. It's a mental process. The biggest thing people learn from me and fellows when they come to me is the pre-op day is where I exhaust myself. The surgery cannot exceed 6 minutes, no matter how complex a case you send me. So this is what we did to this patient. Brought him with a piggyback lens, then the laser on top, 20/20. In fact, he's 2015 and he's got his license back. What does the patient remember? 3-minute piggyback lens surgery, 4-minute laser surgery, 4 months apart. Now, understanding this concept, there is nothing you cannot correct. So here's the patient who had 12 previous surgeries and was written off completely. Broadcaster, a news broadcaster. He's now a pastor because he couldn't see. Keratoconus, intact, PRK, PTK, LASIK, ICL, and now early cataract and cross-linking, everything. Poor vision, nothing to do with Dr. Gulani. Can you do transplant? Something magical to get this guy off my back. Cannot. You have to think 20/20. So because this cornea was improper, I first want always the cornea to be measurable to enter the eye. You cannot put in a cataract lens going, let me assume he'll land at 20/20. That's criminal. So I first do a laser technique. I'll show you. First we do that. Correct the cornea, then ICL removal with aphakia. I wait because accuracy is very important. I have every technology under the sun from even before in the beta systems, but I rely on my refraction on the weekend. He, in fact, made me go fishing, and I did that too for him. I'll never do it again. Very smelly. So here's this full sequence, how he moved in his vision. This is in sequence. Remove the ICL aphakia and basically bring him to 20/20. Here's the surgery for you to see.
In this case, of 12 failed procedures, including intact PRK, PTK, cross-linking, ICL, and now cataract and anterior.
So don't worry about number of surgeries. Doesn't matter who did the surgery.
I first addressed the corneal scars in a laser corneoplastic mode. You see me peeling away the scar
to make it measurable,
followed by laser
application. You cannot have an unmeasurable cornea.
To a nice circular endpoint,
topography in these cases. It's
literally correlates with measurability.
Refraction.
With full confidence now, I proceed with the ICL removal and cataract surgery plan, keeping all the principles I previously described of
have to be artistic, has to be no stitches, attitude has to be adamant, cannot take the easy way
renegotiate the same previous incision, bring the ICL for a nice purchase, hold it and pull it out, keeping full control without any need to increase the incision. On bringing the ICL completely
Always
out,
watch everything we
you
do.
can place
Make
it
sure
on
we
the
don't send the
cornea to
patient
examine
traveling with
for
something half
complete
done.
removal with no tear or any missing pieces, followed by cataract surgery. In this case, I follow and keep this patient aphakic without a lens implantation
To measure.
to ensure even more measurability by refracting this patient aphakic next day and a week later
and a
to
week
follow
later.
with extreme confidence to even put in a toric lens implant in this patient and bring him to 20/20 vision. And you can see the summary right here.
Very important, please keep looking at the patient. That is the biggest way of accountability. So there is no case that you cannot do a strike on. These are patients with scars, RKs, subluxated lenses, have to bring them straight to 20/20. This is a fun thing my fellow did for you, just to show you a surgical strike concept. And how when we prepare, I want the preparation mode to be here. The planning, the surgery is easy. Plan it out like crazy the night before, then show up in your cockpit next day and do your magic. Thank you for your attention.
Thanks, Arun, for that wonderful presentation and the perfect take-home message that meticulous planning and attention to detail and individualizing and customizing treatments to every patient is the key to success. And I think one thing we definitely need to learn from you. Thanks for sharing those lovely cases. If any of our panelists has anything, can you stop sharing your screen, Arun, so that we can have a quick discussion? And we are running much behind schedule, so we'll only take one, panelists to tell us. Dr. Chang, would you like to say something here?
Oh, that was like a motivational lecture there. So I think I loved a lot of the points, and I think focusing on the patient and not purely the refraction is really good advice.
Larry, would you like to say anything there?
I agree. I think that surgical planning is what it's all about, and clearly, these good results are obtained because of the thought that goes into it.
What about intraoperative aberrometry? The systems that we have, the ORA systems, especially when you're putting the intraocular lenses in these complex eyes. Dr. Arun is there? Yes. Absolutely. What is your call? What is your take on that? If you have a system, like ORA, and it'll help you to, titrate your lens power better.
As you know, I'm a beta tester for all technologies in the world, and these do not work in these cases. I have used 3 technologies on this, and therefore I came up with this concept that Dick McCool and me share very deeply is leave the patient aphakic. It increases your work, but that's not the point. So you saw me leaving him aphakic with cortex in the subcortical area, subincisional, day 1, day week refraction, 100% 20/20, even in these cases. So ORAs and all work okay in basic, simple post-LASIK, post-RK. They fail completely. I have seen these patients, again, flying to me with ORA reports from their surgeons. And my take is very simple. Results talk. Refraction is the way to kill this. Surgery is second, but you have to be an artist in that. 3, focus is patient. So using any technology, because my fellows are putting together projects on this now, smooth topography, great transplant, and well-centered lens do not correlate with patient happiness at all. I'm seeing that because 78% of my practice is second opinion. So ORA is great for post-LASIK, post-RK for delegates who are listening. It does not work at all for people who had 10, 12 surgeries. And refraction is your hell-bent point. I keep pushing. A refractive surgeon cannot be a refractive surgeon unless you know how to refract.